I personally have just been really energized, in addition to the Supreme Court decision, by the discussions we've had this morning. I think both sessions were really fabulous. I know I personally learned a lot, and I think we've got a lot of the people in the room that can take the knowledge that we've learned and apply it going forward. So I'm hoping we can start to talk a little bit now about care transitions in our final session, and then Sue will wrap up for us after the session. We're going to hear from David Bass about partners in care and care consultations, and he's going to be focusing on those aspects of care transitions that involve between health and community services. Karen Hirschman, I'm feeling like there's an echo. Can everybody hear everything okay? I may back up a little bit. Karen will be talking to us about transitions between hospital and home, so more of a somewhat narrower slice of care transitions. And then Chris Callahan will talk to us about primary care-based care transitions model that, again, looks across the spectrum. The kinds of questions, so you've noticed a theme here. We have we have our presentations, then we have questions that the panel will address. I know I sent them a list of questions ahead of time, but I want to warn them that one of the things I'd like them to focus a little bit on is, in those areas where they've had clinically significant outcomes, what do they think are the reasons for that? Like, it might be the characteristics of the person with dementia, it might be the characteristics of the intervention itself, it might be a payment issue. So, like, for the statistically significant clinically significant results, what are some of their thoughts about what the reasons for that might be? And also the time frame for outcomes, like, do you see those kinds of changes within 6 months, or is it a 12 months, 18, 2 years? I'm personally convinced that the outcome horizon ought to be, from baseline out several years because of the slow nature of the progression of the disease. And then we want to hear about financial sustainability, I think, and also I really want to hear what folks have to say about their recommendations for policymakers and the private sector too, in terms of what they cover. So without droning on and on, we will, or me droning on and on, we'll turn it over to David Bass right now. Thanks.
So I'm going to talk about a topic related to what Dr. Easom talked about this morning. And care consultation is the name of the generic intervention that Dr. Easom talked about, the Georgia implementation of that. I'm going to talk about care consultation in general and partners in dementia care. Partners in dementia care and care consultation are sister interventions, but partners in dementia care is delivered via a partnership between a care coordinator located in a community agency, like an Alzheimer's Association chapter or an area agency on aging, and a care coordinator located in a medical center. And I just want to point out that Dr. Mark Kunuk and Nancy Wilson are here. They're my colleagues who we all worked together on the original Partners in Dementia Care project that was done in the VA healthcare system. We just finished up a 5-year demonstration and are in the process of disseminating findings from that. We're also replicating Partners in Dementia Care in Ohio with the Cleveland VA and an area agency and Alzheimer's chapter in Ohio. So care consultation is the generic intervention, comes in 2 different forms, the partnership model and the individual agency model. I'm from Benjamin Rose Institute. We delivered care consultation as one of our services. So we're a service and research institute, and so I've had the first-hand experience of what it means to try to recruit and have clients for a program, and actually we tried to get people to pay for this service themselves since there's no third-party reimbursement, and that's an interesting story in itself, so we could talk about that. I might get into a little bit of that. So care consultation, partners in dementia care. One way to think of them is a care coordination method that links community-based services and healthcare services, or medical and non-medical services. Because much of what a care coordinator or a care consultant does is help bridge those two sectors. Helps people find and use community services and helps them negotiate the healthcare system. It helps communication between the two. So ideally, a care consultant will have in the medical record a summary of what they're doing, but even if they're located in the community agency side. So it's that bridge between the medical and non-medical. And 4 types of assistance: linkages and monitoring of services, personalized coaching and information, strengthening the informal network. This is much focused on coordinating family care and formal care as it is coordinating among community services. There's a real strong family formal interface to this, and emotional support. It's delivered by telephone and email. We're doing a lot more by email, as many caregivers in particular are preferring that, but 80% is still delivered by telephone because that's what people want. It could be more computer if people get there and that's their preference. It's a long-term relationship with clients. So one thing I want to highlight is that this is not an educational evidence-based program. This is an ongoing program and establishes a continuing relationship with people. It might be for a year, it might be for 2 years, it might be for the entire caregiving journey. Bachelor's or master's level people from a variety of disciplines have done this. It's really guided by consumer preferences. It's very important because consumers do the legwork here, and the care coordinators facilitate that or coach that. It targets both the person with dementia as well as the caregiver. Both people are of equal attention, and if you look at our computerized record-keeping system, there's a section for caregivers, a section for the person with the illness. Just as important, equal attention. And we think that's very important in terms of caregivers' acceptance of these services, because we know from our research as well as our service experience that many caregivers don't think they need help. They're there as the caregiver. So we find that their willingness to accept help is much higher when you can parlay it together with also helping the person with the illness. And even though today this is about dementia, this intervention is not dementia specific. It started off that way, but we have tested it with people with diagnosed depression, people with multiple chronic conditions, and so it is very generic as far as the types of illnesses. The main focus is simple and practical solutions, not a complicated intervention. If we were to show you how it actually worked, simple, practical steps to help people build confidence, slowly work towards solutions to the problems that they think are important. Very broad range of areas of potential problems are dealt with. So it's very broad, and it's a coaching service. It's not to do, it's to help support. There are 3 main parts. There's a brief trigger-focused assessment. It is assessment light intentionally, because the goal of the program is to get right into what people want to work on. So it's not it's assessment informed, but it is action plan focused, and it's action plan according to the priorities of the caregiver and care receiver. And ongoing monitoring reassessment. As I said, a key to this is that long-term relationship. There's some of the outcomes. We found all kind of beneficial outcomes. Depends on the project, which specific ones we found. There have been 9 studies of this done, and some projects we found reductions in rehospitalization rates in our VA trial with Dr. Kunick and Nancy Wilson. We found rehospitalization reductions, nursing home placement reductions over a 1-year period. In some of the other projects that have looked over a 2-year period, we found also emergency department visits reduced. In addition, we've always found psychosocial outcomes improved. Care-related strain, depression, both on the part of the care receiver and the caregiver. Challenges, marketing to consumers, very difficult, most successful when it's been a program embedded within a larger organization's services, hard to market by itself. There's no third-party reimbursement. That's obviously a major challenge. Effectively interfacing care consultation or partners with dementia care with the rest of the services that are available to people from an organization that's providing the service. This goes back to, I think this ties in with the earlier discussion about these evidence-based programs have to be integrated in with an organization's larger system and a community system too. So there's a lot of levels, and engaging older adults and caregivers when they're not in crisis. But we've always designed care coordination, care consultation as a preventive service, but it's very difficult to keep people engaged over the long term when there isn't something very active that they want to work on. And so just like all preventive health issues, it's not easy to get people to do them when there's not a big problem at hand. So that's an overview. Thanks.
Good afternoon, everyone. So I'm going to tell you today about our transitional care model, which is a little bit different than what we've been talking about today, in that our model, which has been tested over the last 20 years at the University of Pennsylvania School of Nursing, led by Mary Naylor. It's a little bit different because we started out testing it out with people who do not have cognitive impairment. So patients were cognitively intact, and that was a requirement in order to participate in the trials that I'm going to tell you about. And then we've tested it now with people with cognitive impairments. So the way we define transitional care is that it's a range of time-limited services and environments that complement primary care and are designed to ensure healthcare continuity and avoid preventable poor outcomes among at-risk populations as they move from one level of care to another among multiple providers and between settings or across settings. Our model specifically uses advanced practice nurses with knowledge and skill to care for this population as the primary care coordinator as they transition from the hospital to home or to the next setting of care, which might be a skilled nursing facility on the way home. The nurses see the patients within 24 hours of enrollment into the program. They see them at the bedside at the hospital and then daily while the patient's hospitalized. They see them within 24 hours of discharge home to the next setting of care, which is usually home, but it could also, as I said, be another setting. And then if they go to another setting, they're seen within 24 hours of that discharge as well. The nurse is the primary point person here in terms of coordinating the care and working with the primary care providers and specialists in the community. And they make not only home visits, but they sometimes go to the follow-up first primary appointment post-discharge from the hospital. The in-hospital assessment is the key part, where they work with the providers at the bedside and with the patient and the family using a set of risk criteria to determine that the patient's both eligible to enroll, and then looking at what the needs of the caregiver and the patient are as they move forward and what they want to focus on in terms of their goals once they're home. So it is an evidence-based practice, and with the focus of active engagement of the patient and the caregiver. And over 3 randomized clinical trials, we have been able to, with, again, cognitively intact older adults, we've shown better care, better health, and reduced costs over time. Reduced errors, increased satisfaction, or what we now call experience with care, decreased symptoms, enhanced quality of life, and improved function for these patients, and decreased all-cause rehospitalizations, reduced ED visits, and total cost savings, and that includes taking into account the cost of the advanced practice nurse. So we were just talking about this last night at dinner. We were approached by the Alzheimer's Association many years ago that said, this is great, you've shown great work. Now show us it works with people who are cognitively impaired. And so that's what we did. We just finished our study and are in the process of trying to move those results forward, I should say. And we are seeing similar results, consistently demonstrating these results. And these patients were patients who, when they were hospitalized, either had a diagnosis of dementia or were screened for cognitive impairment. So they showed significant deficits in orientation, recall, or executive function. About 25% of this population had delirium as well, and 30% of this population lived at home. We had in our final sample 407 patients and 407 caregivers, and we followed them through 6 months. So these results are all through 6 months, and we are seeing similar outcomes, preliminary analyses for other outcomes that we saw with the previous RCT. In terms of experience with care, decreased overall total symptom burden, and function is questionable, and I can talk about that later, enhanced quality of life, and as we saw, the cost reduction. So we're in the process of analyzing the total costs, as well as the specific diagnosis, so the index hospitalization reason and then related hospitalizations or other reasons for readmissions.